So we shall now go on to our first speaker, who is none other than our esteemed, very versatile surgeon, Dr. SWATHI KALIKI, who is the head of OEU Institute of Eye Cancer, head of Ocuplasty Services, LV Prasad Eye Institute. And she is going to dwell on something very relevant and novel and interesting, the current status of targeted therapy for locally advanced periocular malignancy. On to you, Dr. SWATHI.
Thank you very much, Dr. Chitra, and everyone who have organized this wonderful meeting today. Very good evening to all of those who have joined us. I'm going to share my screen now. Yeah, so I'm going to talk about the current status of targeted therapy for locally advanced periocular malignancy. I do not have any financial disclosures to make, and there will be certain clinical photographs that have been used in this presentation, and appropriate permission has been obtained for the use of the same. Now, whenever we come to a oculoplasty clinic or specifically oncology practice, we do see quite a few eyelid malignancies. And eyelid malignancies, when they are small like this, be it basal cell carcinoma, squamous cell carcinoma, melanoma, or sebaceous gland carcinoma, we can easily excise them and give them appropriate cosmetic results where the tumor also has been taken care of and appropriate cosmesis has been provided for the patients. But rarely we do see malignancies like this, where it is in very, very advanced stage beyond the surgical resection. Virtually, it's almost like inoperable cases. In such cases, what do we do in them? Also, we see cases where there is syndromic association, where there is multifocal lesions. For example, in this lady, where you can see that there are multiple basal cell carcinomas that you can see, one affecting the right eye, of course, and multiple areas over the face as well. And also in the periocular area. So these cases are very, very difficult to manage. And that's when the targeted therapy is actually important in these cases. Now, with advances in the ocular oncology, there is a new paradigm treatment that is now available, that is the targeted therapy. Basically, what is targeted therapy? That is, these are the treatments which work on the molecular pathways of these tumors, and they target and interfere with the cellular signaling pathways. Thus, they take care of the cell, they inhibit the cell proliferation in these tumors, thus helping in cure of these tumors. Now let's take each tumor one by one. We'll start off with basal cell carcinoma, for the reason that great advancements have been made in basal cell carcinoma compared to other tumors. Now, when we talk about basal cell carcinoma, I think it is very, very important to know that this fly called the fruit fly or the Drosophila melanogaster is one which actually, the experiments on this fly have actually revolutionized the treatment that is available today. So it was in this fly in 1980s when it was detected that there is the hedgehog gene that is present, which is very, very important in cell proliferation, which when inhibited can cause adverse effects, or when activated rather causes adverse effects. So what is the hedgehog genes? So basically the hedgehog gene, which was first detected in the fruit fly, later it was detected in vertebrates. 3 different hedgehog genes were identified. The most important of it is the sonic hedgehog. Now, sonic hedgehog signaling pathway is very, very important. It is present in many cells, and it is important for the embryologic development of many systems like the neural tube, the musculoskeletal system, the hemopoietic system, and skin as well. It takes care, it controls the cell cycle regulation and maintenance of the progenitor cells. And when there is activation of the sonic hedgehog pathway, it causes many solid tumors, one of which is basal cell carcinoma. So what happens when the cell is normal? So when the cell is normal, now there is a cell membrane protein called as patched 1, which is in green, which is in blue there, which is now circled in red. That is the cell membrane, the transmembrane protein that is present. It acts to inhibit the other cell membrane protein called as smoothed. So when there is inhibition of this smoothed, it inhibits the transfer of this protein into the cell and thus prevents the activation of GLI proteins, that is the glioma associated oncogenes proteins which are present, which when activated can cause proliferation of various transcriptomes. Now, what happens when in BC or in many solid tumors, including the basal cell carcinoma, is that is when there is no inhibition. So the sonic hedgehog genes, they inhibit the transmembrane protein, that is the patched 1. So when that is inhibited, this in turn, it cannot inhibit the function of the smoothed transmembrane protein that is there. And when this is not inhibited, it gets into the cell and it activates the GLI proteins. And this in turn, it causes many changes inside the cell, which can cause cell proliferation and ultimately the tumors. Now, this is an example of a case of nevoid basal cell carcinoma, or also called as the Gorlin-Gault syndrome. So it is an autosomal dominant syndrome where multiple basal cell carcinomas are present, as you can see in this picture. And they also have dyskeratotic palmar and plantar pitting along with odontogenic keratocysts. Now, this is the same patient where you can see multiple BCCs that are present, and he also had the dental changes that are associated in this patient. Now, to treat this patient, if it was only the eyelid lesion or if there were a limited number of tumors, it's easier to treat. But when there are multiple throughout the body, not just on the face, it is very, very difficult. And also a long time, they develop many tumors. Now, what actually happens in this syndrome? So in this syndrome, there is mutation of the long arm of chromosome on the patched 1 gene that we just mentioned about in the sonic hedgehog signaling pathway. So when that is mutated, so this is obviously inhibited and this gets activated, and also the GLI proteins are activated, which in turn results in activation of the sonic hedgehog signaling pathway. Now, what is the targeted therapy? So once now that we have understood the pathogenesis of basal cell carcinoma, now it is also important to understand that this the sonic hedgehog signaling pathway activation not only happens in the syndromic association of basal cell carcinoma, but also in sporadic cases. It has been shown that 70 to 80% of sporadic cases of basal cell carcinoma also have the activation of the signaling pathway. So if we have to have a targeted therapy for basal cell carcinoma, it has to target the sonic hedgehog signaling pathway. And this may not be required in all cases because when it is small, it can be easily excised. But when it is locally advanced, or if it is refractory to other forms of treatment, or if it is a metastatic disease, or in inoperable cases, then targeted therapy for the basal cell carcinoma is very, very useful. Now, I'm sure many of us have heard this terminology in many meetings where it has certainly made a splash, where it is the Vismodegib. It is a small molecule treatment for basal cell carcinoma. It basically targets and it inhibits the smooth protein, that is the transmembrane protein that is present on the cells. And when this is inhibited, it prevents the entry of this into the cell, and thus there is no activation of the GLI proteins and there is no other changes that occur in the cell. It basically inhibits the sonic hedgehog signaling pathway. Now, this drug has been approved for use of basal cell carcinoma in very advanced cases in the year 2012, and it is given at a dose of 150 milligram once daily. This was the phase 1 clinical trial, which was first done in 2009, where 33 patients were enrolled in this study, and it was shown that 2 patients actually had complete response with this drug, and 16 patients had partial response, and 11 patients had stable disease, but about 4 patients had progressive disease. So it's not that it is useful in every case, but certainly in inoperable cases, in almost about 50% of the cases, it is useful. Now, these are the pictures from the same paper. This was the first, the phase 1 trial, where they have shown that it is effective. Then came the phase 2 trial, which was done in 2012 to establish the efficacy and the safety of this drug for use in advanced basal cell carcinoma. In this, about 96 patients were enrolled, 63 of them with locally advanced inoperable basal cell carcinomas and 33 with metastatic disease. And it was seen that there was a reasonable response rate with 43% response in locally advanced tumors and in 30% of the cases with metastatic basal cell carcinoma. But it is important to note that almost 12% of them had to discontinue the treatment because of the side effects, where the major side effects that occur are the muscle cramps and all the other side effects similar to any chemotherapeutic agent, like loss of appetite, loss of taste, alopecia and all that. But the most important was the muscle cramps, which caused discontinuation of treatment in 12% of the cases. And 7% of them died, but whether the death is because of the drug could not be established. These are some of the pictures from the phase 2 trial study, where it can be seen that there is definitely very good response with this drug, and these patients did not require any treatment. Then that was being used for cutaneous basal cell carcinoma. And then the next study came in where it was used for basal cell nevus syndrome. And in this, again, it enrolled about 41 patients. And it was seen that when Vismodegib was given versus a placebo, these patients had lesser chances of developing newer BCCs and thus requiring fewer surgeries and reduced burden of surgically eligible BCCs. However, 54% of them had to discontinue treatment because of severe side effects. And the other very important thing to note was that the tumors regrew when the drug was stopped. So which means that the drug had to be continued if the tumors had to be kept under control. And these are the pictures from the same paper, where it can be seen that there are definitely impressive results with the total disappearance of the lesions. Then it was used for periocular basal cell carcinoma. So from the year 2012, there have been numerous papers which have used Vismodegib for the advanced periocular basal cell carcinoma. And here are a few examples where there is good response with this drug. So the advantages that have been described are that it obviates the need for surgery, the need for extensive surgical intervention, and the need for exenteration in few cases. But it has not become very popular in regular practice because of the high cost, because you can see that the cost is almost, in the US, it is about $7,500 per month, which means almost about 4 to 5 lakhs in Indian currency. Then they have high toxicity. The long-term treatment is required, which means lifelong treatment may be required. And some of them even develop new carcinomas, new squamous cell carcinomas. So that's about the basal cell carcinoma. Moving on to squamous cell carcinoma. Now, squamous cell carcinoma, the pathogenesis of squamous cell carcinoma is the inactivation of the inactivating mutations in P53 gene and mutations in EGFR. So it is noted that there is overexpression of EGFR in squamous cell carcinomas. So the targeted therapy that has been tried for squamous cell carcinomas are the EGFR inhibitors, namely the erlotinib and the cetuximab. However, this again has limitations, that it is associated with high cost, about 3,000 per month. It has adverse effects, and there is lack of long-term follow-up. And thus, again, it has not been used in clinical practice, and it is still in the clinical trial stage. Then for malignant melanoma, the pathogenesis of this is that, again, there is inactivating mutation of P53 gene, and there are mutations of the proteins in MAPK pathway. So MAPK pathway is a series of proteins where it's a chain of proteins which actually it passes on the signal from the surface receptors to the DNA which is present inside the nucleus. And there are various proteins that are involved, that is the RAS, RAF, specifically the BRAF, the BRAF and MEK and ERK pathway. And it has been shown that BRAF is present in about 66% cases of malignant melanoma and RAS in about 15 to 20%. And the targeted therapy that has been used for these cases is the BRAF inhibitors have been used, and also the MEK inhibitors. However, the limitations are that the drug resistance occurs, especially if only BRAF inhibitors are used, and they can also develop new squamous cell carcinomas, and which can disappear, or they involute once this drug is stopped. However, the new squamous cell carcinomas are less likely to develop if it is a combination treatment between BRAF and MEK inhibitors. And it also has adverse effects, and we do not have long-term follow-up for the same. Lastly, about the sebaceous gland carcinoma. Now, the exact pathogenesis of sebaceous gland carcinoma is not known. Mostly, it arises de novo. But however, because in Muir-Torre syndrome, there is association with multifocal sebaceous gland carcinomas that can occur, probably it could be related to the MMR gene mutation, even when it is not associated with the syndrome. And there is also inactivating mutations of TP53 gene. And it has been shown that there is upregulation, there is overexpression of EGFR. Yeah, I'm almost done. And also there could be activation of Hedgehog pathways. Targeted therapy for sebaceous gland carcinoma, it has not been tried yet. So there are no drug trials yet in this. So based on these, we understand that it is important to understand the pathogenesis of eyelid tumors, to understand about the molecular therapies for these eyelid malignancies, and which could improve outcomes in inoperable cases. So that's all I had for my talk. Thank you very much for your time.
Thank you very much, Dr. Swati. It was so interesting and informative. I'll ask one simple question before I ask Swati to take on. That from what I heard you, is it reserved only for non-resectable tumors, or do you think it is replacing the surgical treatment modality in ocular oncology per se?
No. So even now, yeah.
Thanks.
Yeah. So even now, if it is a resectable tumor, then surgery is the treatment of choice. These drugs are reserved only for inoperable cases or metastatic disease. And also because of the high cost, it is not in routine clinical practice as yet. But I think, yes, it is important for all of us to know about them, because maybe 10 years or 20 years down the line, it may become standard of care. But at this point of time, it is used only for locally advanced cases.
Dr. Swati?
Thank you, Dr. Swati. That was a really something that we should consider probably over time, as you said. As of now, that it is really so expensive that I don't know how much of us can actually put it across to our patients for as a treatment, even in non-resectable cases. Have you had any experiences using them in your practice?
No. So when I was in the US, I have seen a couple of cases where definitely it's like very impressive results. But also the side effect profile is really, really high. And if the patient has to take that lifelong with these side effects, it's like, really difficult. But here, no, I don't think in India anybody has used these drugs. But yes, in the US, I have seen a couple of patients.
So each of these, like even if you use them on a to reduce or chemo reduce like a chemo reduction basically, even after you resect them, do you still have to continue this medication, or you need to?
So if it is a single tumor and if you have used it only as a neoadjuvant therapy, then you don't have to continue it, like neoadjuvant, and then you have done surgery or radiation and then you don't have to continue it. But most of the times, especially the Vismodegib, it is used in the syndromic association patients. And in them, it is mainly to prevent the new tumors and take care of the existing tumors as well. So there it becomes a little tricky, because even if you have surgically resected the tumors that are present, but in order to prevent the new tumors, you may have to continue for long.
For long. Okay.
Yeah.
And then keep them on a regular follow-up to see if there's any recurrence.
Correct.
Has anybody in the panel got anything to add?
Yeah. Expert panel.
Ma'am, Milind
wants to take it.
Okay. In the meanwhile, you want to say, ma'am?
No. It's a great talk, and I think it's the need of the hour, but we have a lot of work to do before we start advocating this, considering the cost factor. So that's all I think we have.
Thank you, ma'am.